Well, good morning, everybody. Thank you for being here, and thanks for those of you who are streaming and watching this in virtual reality land. My name is Peter Wayne, and I'm the research director here at the Osher Center for Integrative Medicine. And I'm so excited about our presentation today by Professor Vikram Patel. We're really in for a special treat, and it's really an honor for us to host him. And today we have an unusual situation where we're jointly hosting this event with the Benson Henry Institute for Mind-Body Studies. So this is another new initiative for us. Before we get started, and Dr. Young from the Benson Henry Institute is going to introduce Dr. Patel, just a couple announcements. First, we're announcing today that we've set the date for our 2020 Network Forum. This one's going to be centered around medical education. It's going to be November 6th, 2020, so save the date. And it's called Learning Horizontally and Vertically, Building Networks Within and Between Healthcare Professionals. And I think maybe some of the issues that are touched on today will be in sync with some of the issues we're trying to address in our network conference. And then the other announcement I wanted to say is that our request for applications, especially the letter of intent, is due January 15th for our pilot research fund. So those of you interested in soliciting some funds for a pilot study, please start thinking about your letter of intent. So that we can use the time to really get into the reason we're all here today, I'm going to pass the podium off to Albert Young, one of my colleagues in mind-body research who's based at the Benson Henry Institute, and he's going to introduce our speaker today. So thank you all for being here.
Thank you, Peter. It is my honor to introduce to you Dr. Vikram Patel. Dr. Patel has been one of my heroes for more than 10 years. I have been following his work. I work at the Benson Henry Institute doing mind-body research, and I also serve in Chinatown working with the underserved population. And Dr. Patel has done what I have been dreaming to do for years, but he has made it a reality, coming up with a system to serve the underserved population all over the world. He is the Pershing Square Professor of Global Health and Wellcome Trust Principal Research Fellow at the Harvard Medical School. And he will tell us about the economic and social consequences of poor quality care for chronic diseases and how his work has improved the quality of care for people with chronic disease in resource-poor countries and communities. His research has challenged many of the myths surrounding mental health problems in the global context, demonstrating that these problems are universal forms of human suffering, that there is a vicious cycle of deprivation and poor mental health, that mental health problems profoundly affect the physical health and well-being of affected persons, that psychosocial interventions can be effectively delivered by widely available and affordable community-based providers. And this is very exciting. And that human rights of people with mental health problems to access quality care and to a life with dignity are global concerns. This model has applications to the primary care treatment of depression, anxiety, alcohol use disorders, the community-based care of people with schizophrenia, autism, and the prevention and treatment of adolescent mental health problems through school-based interventions. Among many of his accomplishments, Dr. Patel co-founded the Center for Global Mental Health and the Mental Health Innovations Network at the London School of Hygiene and Tropical Medicine, and the Movement for Global Mental Health, which is the largest global network of individuals and organizations advocating for promoting services and human rights for people living with mental health problems. In 2018, he co-founded the Global Mental Health at Harvard initiative, which is developing a suite of innovative interdisciplinary initiatives aimed at implementing and generating knowledge to transform mental health globally. Without further ado, we welcome Dr. Patel.
Well, thank you very much for coming at this very, very early hour. My talk today is really about something that's extremely close to my heart because I'll be drawing very heavily on my mom's story. It's about living with multiple chronic conditions at the same time. Many of you will already, living in the US, be aware that chronic conditions, what we used to call non-communicable diseases, but actually that's not such a good term, because chronic conditions also include infectious diseases like HIV. And these conditions are already the leading causes of death in the US. They're the leading causes of years lived with disability. But few people know that these are also the leading cause of death and disability in the global South. For many people, the idea is that infectious diseases, maternal health conditions, and so on dominate the burden of disease in the global South, but that is not the case. Already more than 2/3 of all deaths in the global South are accounted for by chronic conditions. And of course, as you will see with the epidemiological transition, this proportion is going to continuously increase. And so there are very important questions of how do we address chronic conditions in situations and contexts where almost the entire focus for the last 100 years has been on the management of acute events, either acute infectious disease events or acute traumatic events. So these are conditions, of course, as you know, as the name implies, will live with the patient, live with the person, in fact, for much of the duration of their lives. How do we actually address these health conditions, and they often coexist as well, in the face of the fact that the health systems globally are ill-prepared to deal with them. Now, in recent times, there's been a lot of excitement, particularly in our medical school here, with terms like person-centered medicine, which of course refers to tailoring therapeutic interventions to match biological characteristics of a particular individual. There's a lot of excitement, of course, because, biology is at the heart of a lot of what we do. However, the way I am going to be presenting this talk today actually looks at a very different aspect of the person, not his or her biology, but his or her personhood. And I'm actually going to start by telling you a little bit about my mom. I have to just tell you this conflict of interest. So that's a picture of my mom taken about 2 years before she passed away. And the piece I'm about to tell you about is, it was published as a very personal article that I wrote in the Lancet in their Art of Medicine column. So to tell you the story of my mom, I have to start with her birth. She was born in 1936 at a time when India was still a British colony. And she was married at the age of 18. And then had, as very many women in India do, had 3 children in rapid succession. The first child was my elder sister, the second child was my next sister, and I was the youngest. Now, it's important to really point out that when the second child was born, in an Indian family, it was extremely important for a woman to have a boy. And having had a second child, which was a consecutive girl, my mother recalls, I took an oral history with my mother many years later when I tried to understand the life course story of her epic struggle with chronic diseases. So it really began after the birth of her second child, the girl. And she remembers that unlike the first child, where there was a huge family celebration, typically in Indian families, you distributed sweets, there was a huge celebration in the hospital. When the second child was born, she was completely alone with her new daughter, to the extent which not only were sweets not distributed, but in fact she had to come home alone with her daughter, which was unheard of, unthinkable really, just with the family driver. And she remembers that shortly after my second sister was born, that she started developing very significant complaints with sleep. She couldn't sleep at night. She felt very miserable. She can remember vividly feeling very tearful and really quite a bit losing interest with her newborn daughter, which completely shattered her because, of course, she did not feel that the newborn daughter was unwanted. She remembers then that she was referred to her general practitioner, the family doctor. And the family doctor did as they did in those days, in the 1960s, remember, started prescribing her with barbiturates. These were, of course, very commonly used medicines in those years, and they were seen as a panacea for pretty much every emotional problem, and of course also as a very powerful hypnotic. So this is when she started her barbiturate medication. And then it turned out when I was born, around the time that I was born, the family doctor became aware of the fact that my mother had become addicted, a little bit like the opioid crisis that's unfolded 30 years later. He became aware that she was addicted now to barbiturates, and she couldn't sleep, she couldn't also function, and she was actually asking for these drugs in the morning. Mind you, this is a woman who had no previous history of substance use, so this history of substance use was really triggered in this way by an iatrogenic factor. Now, curiously, in my family, we were one of the few families in Bombay in those days. My grandfather, who was a patriarch of the joint family, was a civil servant, and civil servants were very anglicized in those days, at least. And so drinking alcohol was a very well accepted practice in my family. So in his wisdom, the general practitioner advised my grandfather that in order to wean my mother of barbiturates, that maybe she could be introduced to drinking alcohol. So this is how my mother's transition moved from one substance of abuse to another substance of abuse. Now there's a gap of 30 years. During this period, my mother had no real contact with the medical system, except for the fact that she was gradually becoming sicker, both due to alcohol abuse. She had now become completely dependent on alcohol. She was drinking now early in the morning as well, without, of course, anyone in the family knowing. But also, unknown to us, there was an incipient diabetic disorder that was beginning to take hold. All through this time, of course, she was also suffering from a mood disorder, which had remained essentially medicated by alcohol. In 1994, because of the initial emergence of diabetic complications, diabetes was diagnosed. It was only after the diabetes being diagnosed 2 years later that her depression was diagnosed. And mind you, this was not by a psychiatrist, but by her diabetic physician, who I'll always be very grateful to, because I remember, called me one time when I had returned to India. I used to work in Britain as a psychiatrist. He said, "Hey, son, you come to see your mom. I think you should just talk to her a little bit and find out what her mental health is like." And I said, "No, she's completely fine." Even I couldn't see it. And it really showed to me, it displayed to me how often mental health concerns are often hidden from you, even from someone who considers himself a pretty good clinician. So her depression was diagnosed by a senior psychiatrist in Mumbai at the time. She was started on nortriptyline. But by now, really, her body had been very heavily damaged by a combination of alcoholism and really undiagnosed and untreated diabetes for nearly 2 decades. She suffered her first stroke in 2003. And finally, as a thanks not just to the stroke, but also, and I'll return to this later on, to the unstinting support of my dad, she finally stopped drinking about 30 years after her history with alcohol had begun. In 2013, she had cancer of the colon. This was obviously unconnected with any of the other risk factors, but luckily she survived that. She was surgically treated for cancer of the colon. But really, unfortunately, a year later, the diabetes finally caught up with her. She developed end-stage renal disease, had to be put on dialysis. She developed gangrene of one of her peripheral extremities in 2015. And she passed away in 2017 with multi-system failure, to a large extent because of her diabetes. Now you can see why I said this is an epic struggle. But interestingly, of course, this is not a unique epic struggle. Now, during this entire course of her sicknesses, through all these different organ-based disorders, she saw multiple different specialists. And because I was a physician as well, she often saw very good specialists who were often colleagues of mine who had been through medical school in Bombay with me. They were very concerned with my mom's well-being, but primarily concerned with the particular disease that was being presented to them. So they had very little coordination, even though they worked in a great hospital just like the Brigham. And she would have multiple admissions under one physician or another, or a surgeon or another, depending on what was the presenting complaint that led to the admission. And typically, as the admissions mounted, so did the variety of different interventions, diagnostic and therapeutic, accumulate in her medical notes. And I really wanted to show you an example of one such result. This is a prescription that she received on discharge from one of her admissions. You can, thankfully the doctor was very helpful. He counted them out so that my mom didn't have to count them. There were 24 different pharmacological prescriptions, but there was also a bunch of other things that needed to be done. Through all this care, I really felt very, very disturbed by the lack of attention to my mother. It seemed that everyone's attention was focused on the disease or the particular disease that my mother had. And I was very dissatisfied, and there was growing dissatisfaction amongst my sisters, my father, that the quality of care she was receiving was extremely poor. However, India, of course, is a very unequal country, and my mother had a caretaker at home. And she would tell me something quite different. Yes, your mother is miserable, but at least she's alive. Because if even one of these multiple conditions had affected someone in my family in the village I live, she would have died a long time ago. Because, of course, there isn't the one India, just in the same way that there isn't a one US. There is a part of India in which people like my mom, coming from a upper middle class family, could access hospitals that could easily double up as a 5-star hotel. But then there's people like the caretaker of my mom who would be forced to go to these sorts of places called primary health centers, where typically there would be vast numbers of people. The primary health center was completely unprepared to deal with chronic conditions. There were no diagnostic tests available there. There was virtually no time for the physician to really care for the person beyond giving a prescription within 30 seconds. And of course, there was a very limited number of drugs available and almost nothing by way of psychosocial interventions. It's because of these two Indias that typically poor people begin their journey in navigating the healthcare system in clinics on the right-hand side, but because of very poor quality of care, they usually find themselves in hospitals on the left-hand side. But of course there, most of the care has to be paid for out of pocket. What happens as a consequence of this healthcare system? Now, some of you may not be able to completely appreciate this, but in my 2 years that I've been in this country, I've discovered that there are actually very interesting parallels as well, even though this is an unimaginably wealthier country than India. Here is an example of what happens. And this comes from the very important work done by Dennis Xavier and others that has looked at the quality of care for people with acute coronary syndromes when admitted through emergency services at a range of different hospitals in India. And what it shows you is the proportion of people categorized according to their income status who will receive a particular investigation or a treatment related to the acute coronary syndrome. And just to illustrate one example of the inequity with which these interventions are offered, I'm just going to use the example of a coronary angiography. What you can see here is that nearly half of all rich people were offered a coronary angiography, but amongst the poorest quartile, it was less than 10%. And you can see there's a very neat gradient. That is to suggest that the richer you are, the more you are offered for exactly the same clinical presentation in the hospital. And you can draw your own conclusions as to why that might possibly be the case. There are many possible reasons, by the way, and the ability to pay is only one of them. There are also, of course, issues to do with human dignity and respect in the way people who are poorer are treated by exactly the same hospital, which is managing people from very diverse income backgrounds. This is, of course, primarily, though, driven by the ability to pay. This particular slide, although it's a little outdated, in fact, I would imagine that these data are even worse now, shows you the incredible inflation in healthcare costs through out-of-pocket healthcare expenses in India by a range of different chronic diseases arranged here, as you can see, from heart disease on one side to cancer. This range of inflation outstrips almost any other factor that one might consume, any other product that one may consume in India. And there's a profound economic impact that is as the consequence of this out-of-pocket expenditure. In this slide, what you can see is 4 countries. This is a major World Health Organization study led by Mark Huffman, which looked at what is the way in which people finance these acute catastrophic events related, in this particular case, to a cardiovascular disease event. And you can see these 4 countries, again, the populations are organized according to their income brackets. And there are 2 kinds of ways that are being described here that people finance their out-of-pocket expenses. One is through distress financing. And of course, catastrophic health spending is more of a reflection of the overall proportion of their household income that was spent in healthcare. And as you can see, in the case of India, out here in the middle, in the third set of countries, that nearly 90% of people in the poorest tertile of families had incurred catastrophic health expenditure due to a single event of hospitalization due to cardiovascular disease, and more than half of them had incurred distress financing, which simply means that I had to sell something in order to actually pay for these costs. What kinds of things do people sell? Typically jewelry, because this is something that all Indian families will accumulate. This is also a sign of wealth in India going back to times immemorial. But also sometimes selling more precious things, for example, mortgaging your property. Now this slide, again coming from Dennis's paper in The Lancet, shows you the consequences of poor quality care. It isn't only the case that actually rich people get more irrational care, which is one of the possibilities, of course, for seeing that gradient, that the more you earn or the more you can afford, the more care you get, but that care is not necessarily the right care that you should be receiving. But on this slide, you can see here that, in fact, that care might be actually good quality care because the mortality rates amongst the richest quartile are the lowest compared to the poorest quartile. Now, what's interesting is that what Dennis did was that he then adjusted for the kinds of interventions, diagnostic and therapeutic, that people received, and found that when you adjusted for quality of care, this differential in mortality disappeared, which simply meant that when poor people got poorer quality of care, they were likely to die more often, primarily because the care was inadequate rather than because they had a different kind of clinical syndrome that superficially or phenotypically looked the same. So this is the situation with care, not just in India, but it would be fair to say in most of the world. In most of the world, disease-focused care of people with chronic conditions dominates, and I think this is probably also true right here in the US. The person is lost from the picture. What we're really, each of us, focusing on as a psychiatrist, are focused on the mental health problem. Some of you may be diabetologists, and you do the same with diabetes, etc. We really focus on our diseases. And of course, this is a well-known fact which led to the emergence of the idea of person-centered approach, that is, to keep the person at the center of all clinical decisions. This is essentially summarized as the delivery of care for people with chronic conditions and associated risk factors, which focuses primarily on integrating this multi-morbidity care within primary care and addressing these multiple morbidities concurrently within a primary care system. I think most of us would accept that this is really an aspiration that we'd like to realize, not just for other people, but seriously for ourselves. I think as each of us grows older, we're all going to be at one time or the other affected by one chronic condition or the other. And we all hope that one day when we go see a primary care practitioner, most of our care could be delivered there in a way that is person-centered. There's many good reasons for us to have integration. I think all of these are well known to you. So I won't really reiterate the reasons for all of these, but really ask the question, how do we achieve this goal of person-centered care in the way that each of us would like to see happen? Now, over the last 15 or 20 years, there have been many groups that have been trying to address this question. And what I really want to focus on is on two different delivery strategies. One that is extremely well known to you all, so I won't spend very much time on that. But another, which I'm very excited by, but which is far more recent, and I will draw upon work that's done by my colleagues in India, but across the world through the World Health Organization. I will spend a bit of time on that as well. So the first approach, of course, is something that is very, very well known. Collaborative care, of course, this is something that emerged for the first time through colleagues who are working on the West Coast of the US. Essentially, the idea that the management of chronic diseases needs to be seen as a collaboration between the primary care practitioner and the specialist, but at the heart of this collaboration really is the person with the chronic condition, and oftentimes, because most people live with families, we need to also acknowledge the burden of care that falls on families. And I think for those of you who've seen my mentor's book, Arthur Kleinman's book, The Soul of Care, I'd really recommend you to get hold of that book. It really describes very beautifully how, in fact, even in modern-day America, families are by far and away the most important caregivers for people with chronic conditions. And I'll return to this because it is relevant to my mom's story about how we often, typically in our way of approaching the person, we forget that the person lives with a family. So these are the principles that we elaborated. We looked at more than 75 randomized controlled trials, including the work that I myself have been doing over the last 10 years on collaborative care, and identified these 5 key ingredients that go into most collaborative care models, that you are proactively detecting and opportunistically looking, for example, for risk factors that can actually later on lead to poor health outcomes. Typically, there isn't a one-size-fits-all, which dominates our thinking from infectious diseases, right? So if you think about malaria, and this is typically the example I give in the Global South, it doesn't matter who you live with. It doesn't matter whether you're a man or a woman. It doesn't matter whether you use substances. It doesn't matter what other conditions you suffer from. Everybody gets the same regimen of antimalarial drugs. It is a one-size-fits-all way of thinking that dominates infectious diseases, and we willy-nilly just simply applied that one-size-fits-all approach to a far more complex set of health conditions, where typically you have to tailor a combination of pharmacological and psychosocial treatments in a stepped care manner. The third ingredient is having a long-term view, so that you have proactive long-term monitoring and support for adherence with both behavioral and pharmacological interventions. You're not only concerned with disease-specific outcomes, but very importantly, and I'll turn to this when I talk about the second innovation, to social and functional outcomes. And of course, there is a very central role of enabling, mobilizing, and catalyzing the ability of the person for self-management. This is an example of just two different trials that demonstrate that collaborative care isn't only useful for single chronic conditions, but for multiple morbidities. And in fact, when you do this, you actually improve all the morbidities simultaneously and have incremental benefits on person-centered outcomes such as function. Now, the heart of collaborative care is this idea of collaboration. This is an image that I've taken from the team care model, which is really pioneered from UW in Seattle, the concurrent management of cardiovascular disease, metabolic conditions like diabetes, and comorbid mental health conditions such as alcohol use disorders and depression. Both of them, in fact, when I think of my mom's story, she had pretty much all of these. And a key human resource that is central to making this glue happen, to really link all these different providers together, is what in the US is called a case manager, but which in the Global South we often refer to as a care coordinator, but indeed also a community health worker. The community health worker, who is a human resource that has been widely used in the last 2.5 to 3 decades, particularly for maternal and child health care, but also for HIV care, is now being repurposed or redeployed to act as effectively the case manager for chronic diseases. And it's particularly useful in the Global South because, as I will turn to in a moment, much of the care for chronic diseases needs to happen at home. And community health workers, by their very nature, of their orientation, have always been community-facing and delivering care at home. So it's not a huge leap for them to actually just simply shift from a narrow focus on infectious diseases to a broader enablement for addressing chronic diseases, but with a very strong focus on home-based support. Now, again, when we looked at this large body of evidence on collaborative care and looked at what are the kinds of tasks that the community-based agent, care coordinator, case manager, call it what you will, what are the kinds of tasks that or competencies that they need to have in order to be effective? And this is just a summary of some of the key things that these frontline providers are required to do. Obviously, education, adherence support. I thought the third one is really interesting. This happens particularly in collaborative care for people with serious mental illness, just being there. That's all there is, just being there. You don't have to actually even do anything, just to be there to provide social support, company even, oftentimes for people who are actually isolated. And it's quite interesting. I often draw the attention of medical students to the fact that we now know that loneliness kills. Well, if loneliness kills, then maybe befriending is just as therapeutically important an intervention as any medicine we can provide. Proactive monitoring is, of course, a key element of long-term care, so that you can detect a relapse early and provide appropriate referral and navigate the healthcare system, promoting healthy behaviors and lifestyles, particularly around substance use. But interestingly, more recently, and this of course draws heavily on my own work and that of people like myself working particularly in mental health, the delivery of empirically supported psychological treatments, such as, for example, motivational enhancement for alcohol abuse and behavioral activation for depression. This is actually, in my mind, one of the most exciting pieces of evidence in global health today, the demonstration that frontline providers with no prior training in mental health can be trained to deliver highly effective psychological treatments with the appropriate training and supervision. This evidence base is now so large, at last count, more than 75 randomized controlled trials specifically on this particular question, that we now have a range of evidence-based reviews. These are just some examples of reviews that have been led by people that I have the privilege to work with, not only from the Global South, but as you can see from the middle paper, also from the US. The use, of course, again, terminologies vary a little bit. You know, in the US, we call them paraprofessionals, but actually they really describe pretty much the same kind of provider. A provider who is working within a collaborative care model, is not a specialist, is working very coordinated, in a very coordinated way with the primary care practitioner and the specialist, and provides the essential glue, the human glue that connects all these pieces of a very fragmented healthcare system together. The second innovation, this one I'm really excited about because I've been seeing it develop over the last decade. I personally am using this mostly in the area of child health, and perhaps if we have time in the discussion, I'll explain how, particularly in the area of child development, really. But this is to do with moving our needle from thinking about what is the matter with a person, which is typically the kind of biomedical approach. What's the matter with you? Do you have diabetes? Do you have a cancer, etc.? To what matters to you, which, again, I think a lot about my mom here. What really mattered to her wasn't her diabetes. What really mattered to her wasn't her depression. What really mattered to her wasn't her colon cancer. What mattered to her were a range of different functional and social impairments that were typically transdiagnostic. They were really affected by any one of these different diagnoses, and it was relief from those particular impairments that she sought the most relief, and to which she got the least attention. This was published last week. This is work that I have been following for more than a decade because it's been led by a very dear friend and long-standing colleague, Martin Prince. And the lead author was actually my mentee at the Public Health Foundation of India, because this is work we began together in India a decade ago. And I was thrilled to really see this work finally emerging and being published last week. And the idea behind this work is quite simple. The idea is really to address multiple morbidity, of course, the subject of my talk. In this particular slide, you can see not only how the prevalence of multiple morbidities are increasing. As multiple morbidities accumulate, the prevalence of dependence increases quite dramatically, and this is work from the 1066 Dementia Research Group. As well as when multiple morbidities accumulate, the probability of admission to hospital increases. This is essentially a reflection of the increasing needs that people experience as morbidities mount. Now, typically, our biomedical approach really is symbolized by the left-hand column on the slide. We, as in my mom's case, would have multiple different specialists who would then deal with each of these different health conditions. However, over the last decade, we have begun a movement towards transdiagnostic impairment-based approaches, and we think that these approaches are far better suited, not only for the person, but also for the kinds of skills that a frontline provider has, so that the frontline provider doesn't really need to diagnose a person, but actually assess a range of impairments, as you can see on the right-hand side. We then have to ask the question that if we move away from diagnoses and focus on impairments, what is the evidence base for addressing those impairments? Because there is an evidence base, for example, for incontinence. It doesn't really matter necessarily what your primary diagnosis is. Many of the interventions to address incontinence will remain more or less the same. And similarly, for sleep problems or immobility or falls. This is the origin of how the ICOPE program or initiative at the World Health Organization through the Department of Aging was launched. And very recently, and that you just saw the paper that was published last week in PLOS Medicine, this integrated care manual was published, and where the focus is entirely on the management of impairments. As you would want to do with any disease-based treatment guideline, this particular program sought to identify the evidence on specific interventions for each of these impairments. And this particular slide is just there to illustrate to you the range of different interventions that were identified for each of these impairments. And as you run your eyes down that list, you can begin to see how these are actually, to a large extent, transdiagnostic. Some of them, of course, do require inputs from a more specialized provider, and that, of course, would be a role of the frontline caregiver to be able to navigate after an assessment of impairment according to the nature of the impairment to a specific provider. A lot of this, though, can be provided directly by the community health worker. So if you see, for example, low mood, which is a particular area of my work, you can now see how it connects with my previous delivery strategy. That is to say, the frontline provider not only can assess mood, but can also then subsequently provide the brief behavioral activation. The last one, though, is extremely important, and I will close my talk with that. This is a rather complex theory of change, but what this really is trying to illustrate is that by focusing on specific domain-level outcomes, on the left-hand column, you can see the different intervention domains, and then in the second column, you can see the specific outcomes that one can evaluate the impact of the interventions. And so the theory of change really is that, of course, there are lots of arrows in all directions. The point is that these are highly synergistic and interacting, and that what ultimately these focus on are the quality of life and reducing caregiver strain, and ultimately also reducing unnecessary health expenditure. So the ultimate goal is not only person-centered in terms of social and functional outcomes, but also person-centered in terms of reducing overall disease progression and reducing the economic expenditure. So where are we now with this model with ICOPE? A large randomized controlled trials are now being initiated in several countries, focusing on sub-Saharan Africa and South Asia. But it really reminds me that we should be doing these kinds of trials right here in the US, because in fact, this is just as pertinent a question. It's really interesting how these innovations are happening in the global South. And I often think that right here in the US, we escape all these innovations because somehow people see us as not being in the global South. But I actually do think that there are very, very similar challenges, both for people with chronic conditions as well as for a healthcare system that is able to afford this incredibly specialist-led biomedical system for managing these chronic conditions. I want to finish now by thinking about why person-centered care goes beyond the individual. So again, this is a picture of my mom. And as you can see, there is a missing half to that picture, and that missing half is my dad. Now, as you can see, my dad, who's still alive, but suffers also from multiple morbidities. He's 86 now. As you can see very clearly from this image, he struggles with obesity, but he also struggles with diabetes. He also struggles with hypertension, but thankfully, he doesn't have a mood disorder. In fact, he has terrific spirits. He was an incredible caregiver to my mom. Went with her with every single of the more than 200 or 300 appointments she must have had just in the last 5 years of her life with a variety of different incredibly thoughtful, compassionate physicians. And yet not one of them ever asked my dad, "Hey, Harshad, you're putting on weight. Hey, Harshad, how are things? Are you okay? Hey, Harshad, should we also check your blood pressure? Have you had your blood sugar checked in recent times since you obviously live in the same household?" Not once did I, and of course I used to go as well to many of these appointments. I was astonished that no one actually asked my dad how he was doing. And it sort of launched in my mind. Of course, I could see that there was a huge clustering of chronic diseases in my own household or my parents' household. And it got me thinking, do chronic diseases coexist in the same kind of way that infectious diseases coexist? Does having a chronic disease actually in the household increase my risk of developing a chronic disease through a variety of different mechanisms that we can talk about, including shared risk factors? We all eat the same food in the same household, but also through stress pathways. We know very well now that stress triggers a whole range of inflammatory pathways, that this affects a whole range of different autonomic functions as well. Could this, in fact, biologically increase our risk of chronic diseases? Now, it's very hard to actually find data sets that allow you to examine this at a population level, because typically when you do population level epidemiological studies, you actually want to avoid clustering at the level of a household. So typically you only choose one person in the household. So the very question we wanted to ask, do chronic diseases cluster in households more than by chance? We had to look for an appropriate data set. Luckily, my colleague, Dr. Prabhakaran at the Public Health Foundation of India had one such data set. And along with a mentee, who also has the same surname as me, but that's not me. Her name is Shivani from Emory. We were able to use a data set that existed for a completely different purpose, but where more than one adult in the household had been phenotyped for a range of chronic conditions: diabetes, hypertension, depression, alcohol use disorders. It was a population-based data set for more than 2,500 households. We asked us two questions. Number one, do chronic diseases, no matter what the phenotype is, cluster in the same household more than by chance? And secondly, do they actually cluster across phenotypes? If I have diabetes and my wife has diabetes, that seems reasonably plausible. But what if I have diabetes? Is the risk for my wife having depression raised? Cross-phenotypic clustering. So what we find, and I'd encourage you to see the paper to see these results in more detail, irrespective of familial relationships, so these are including marital relationships where there's no genetic co-inheritance, adults who resided with another adult with a chronic condition had a 30% increased adjusted relative odds of having one or more chronic condition. But what's even more amazing is that this applied across diagnostic phenotypes. Now, it's the sort of thing which, is something which fascinates me. I've seen it in my own family, that there's something going on in households in the same kind of way that we think of TB. That, if you have a person with TB in the household, what you do immediately screen everyone else in that household for TB for good reason. Well, I'm beginning to wonder whether this is the sort of approach we also should be using for chronic diseases. I want to end by just telling you a little bit about where I see this work heading in my own area. This is I work predominantly in the Global South, but I'm also beginning to launch work in this kind of area here in the US, which is my new home. So this is on the left-hand side, you can see here is what we typically do. A lot of work has gone in the last decade or more on integrating the care of specific diseases like hypertension, diabetes, or depression, primary care, using collaborative care. And now there is also a nascent but exciting body of work showing how we can use the same collaborative care model for managing multiple morbidities with the primary delivery platform being primary care. Where I really want us to see us going is community-based care, with no longer a focus just on the primary care facility, but actually the homes of people with chronic conditions. And I'd say this is especially true for older people, where the focus is no longer on diseases, but a transdiagnostic attention to impairments, where the focus is not only on the individual, but actually the whole household. Ultimately, and this is a piece we just published last month, for me, re-engineering person-centered care requires attention to what I use as a mnemonic, just to make it more interesting. The 5C approach, one that is collaborative between different players in the healthcare system, but importantly, the community-based worker who provides coordination between all these different levels in the healthcare system, that has a long-term and continuing outlook, unlike the dominant acute approach that occurs in most parts of the world, that is community-facing rather than facility-based. And I think, again, I draw heavily on Arthur's book, The Soul of Care, that really reminds us all that at the heart of the care of chronic conditions is the word care. I want to end by this particular wonderful sort of saying by Laura Gilpin. Plaintree, some of you will know, is an American charity that has been championing a coalition of practitioners towards person-centered care. And what she writes is, what patients want is not rocket science, which is really unfortunate. Because if it were rocket science, for example, you could see the metaphor with person-centered medicine, we would be doing exactly that. We're great at rocket science. We love rocket science. What we're not so good at are the things that are so simple and basic that we completely overlook them. Thank you very much.
Thank you so much.
Thank you.
I think we have some time for some questions.
Thank you so very much. I had never put this together before. I immediately thought of my friends, husband and wife. She's had what's the fibromyalgia and bipolar, which had been under control with talk therapy and pharmacology for years and years and years during the whole marriage. And now he's got Lewy bodies, and when undiagnosed for a long time, it was just perceived to be behavioral. And do you see connections like that, or?
So, you know, first of all, we have to you have to accept that as multiple morbidities become more common as we age, there is a completely chance event possibility, right? That two people in the same household will have multiple morbidities simply because of their natural biological aging process. What we were able to show is that the odds are greatly increased over and above that chance event. And I think this is very new in many ways. I know that there are now similar studies taking place elsewhere. The problem has always been, as I mentioned to you earlier, is the very design of epidemiological studies that makes it impossible to test this hypothesis. But I know that, in fact, people are doing this kind of work. If it is indeed the case that this work is replicated, it does suggest that there's something pathological of living with someone with a chronic disease. That is to say, there's a pathogenetic mechanism that enhances your own probability over and above simply the chance observation. So I've thought about what those reasons could be, and I already mentioned those. It can't be shared genes for obvious reasons, because these are unrelated individuals living in the same household. That could be explained between a child and a parent, but not always between couples. So the one thing is the shared risk factors that operate in the home. In India, for example, the dominant examples would be diet, but also indoor air pollution, which is something you don't see here. But that's where people cook at home and they use fuel, which produces a lot of smoke. And so obviously everyone in the household is inhaling the same air. You know, air quality will be the same for everyone, etc. That would even probably go beyond the household, even the neighborhood. But I think what I'm more, so that's an obvious, so that you work with the whole household to think of healthier diet, healthier air quality, etc. However, what I'm more fascinated by is the emerging biology of stress-related responses, and in what way does caregiving that is unsupported and therefore leads to stress trigger biological pathways in the caregiver that enhances their risk of chronic diseases. To me, that's a more tantalizing possibility, because obviously that opens the door to a completely different set of interventions that are really targeted on the caregiving process rather than on either of the two individuals.
So given the accumulating evidence, is our governments looking at and considering funding mechanisms, and what is the potential for that becoming part of a revised healthcare system in this country?
So, you know, in the global south, people look with terror at what's happening in the US. Because if the healthcare system in the US becomes the norm in the global south, the world will be bankrupt. As the numbers of older people are growing exponentially, and they are growing exponentially, make no mistake, for all our focus on child health in the global south, which I completely support, the complete and total obliteration of the care of the elderly is a matter that is of huge concern to me, because the numbers of elderly people are growing rapidly in most parts of the global south, and healthcare systems are completely ill-prepared to address chronic diseases. And so the models that we use here, which are highly specialist-led, which involve professional caregiving, etc., are simply never going to be affordable in most parts of the world. And so, yes, there is an interest. And if I have to predict the future, I think the most innovative work will happen in the global south, because that is where there isn't actually a landscape that already exists. It's much harder to deconstruct a landscape than to build from scratch. And I think when you actually have nothing, you can actually build these sorts of models. So it's not surprising that the WHO ICOPE is being predominantly tested in the global south. And it could well be, and I hope it will be, that these approaches will then be reverse engineered, you know, for the US, for example.
Thank you so much. I heard you last year at Tufts Medical Center, and I teach using all of your stuff in my global health class down the street. And what I'm interested in today is that focus on impairments. I understand that. And I wonder how you feel about looking at your mom, for example, through a strengths-based instead of impairment-based lens, even just a little.
Yeah, that's a great question. I like that question, and I haven't mentioned that at all. And I think, I think you're absolutely right. When you are assessing for impairments, what you're really doing is a more comprehensive assessment. And this draws me back. If you remember, I said I work mainly with children now using the approach as a strength and difficulties approach. So that also moves away from diagnosing kids with ADHD or autism or intellectual disability, but simply looking at what are your strengths and difficulty across developmental domains, for example, executive functioning, mobility, language, etc. And it's so much easier for me to relate to that because I do a lot of that work as part of my own research program. It's so much easier to work with a parent and a child to say, your kid's doing really well in their language skills, but he's having a little bit of difficulty with fine motor skills. And so why don't we now look at these sets of exercises to improve fine motor rather than saying your kid has a grade 1 cerebral palsy and that is what we're going to actually have to treat. It just changes the whole framing of the problem around strengths and difficulties. So you're absolutely right. And for my mom, her greatest strength was her amazing inner resilience. That she was able through all these 20, 30 years of chronic conditions show unbelievable compassion to everyone else in the family, put her own needs second, etc. And her second greatest strength was my dad. And I think, it's so important for us also not to just assume that a strength can be taken for granted. And I often look at my dad now and I think, every physician around my mom assumed that my dad would pick up the load. Without for a moment thinking about what that implied for his well-being. And I think that's something which I take away. But you're absolutely right. It has to be comprehensive because you want to leverage the person's strengths in order not just to patronize and make it a passive process of care, but an active engagement. Thank you for that question.
Can I build on that question?
Yes.
So this idea of either working with strengths and limitations at one end, treating what's really important to the person. But somewhere in that spectrum, in Chinese medicine, for example, they talk about treating the branches, those issues that face people every day. But then while you're doing that, also treating the root. Because unless you treat the root, you're just sort of fighting these symptoms or limitations. I'm wondering where your model is in terms of treating the underlying causes of these limitations while you're also treating these limitations that are at the front line to the person.
Yeah, so a lot of this, you're right. A lot of the ICOPE techniques you will have seen are really treating the ultimate impairment. The causes may be sometimes very hard to actually identify and treat without a very much more sophisticated medical assessment. So I'm not for a moment suggesting that you shouldn't also have a more etiological assessment. I think that is important. If my mom didn't know she had diabetes, then for sure she wouldn't be able to control it. And the blood sugar was, of course, a key driver of many of her impairments. So it's not an either-or approach. It's really a call to action that we address what matters to people in addition to what matters to the physician.
Yes, I wanted to address something called harm reduction. I actually work as a nurse in case management with Medicaid, Medicare patients, mostly of Latin origin, which is nice because there's always family. But kind of what I wanted to look at was in trying to maneuver the system to get the care to these people that need care. Harm reduction is a term that I can use to get people to pay attention within the system. And I can also work with the specifics of that within the families. So instead of looking just at the diseases, I'm looking at how to motivate them to take the first step, how to begin to motivate them to reduce the amount of sugar in their diet. Like this week we'll do this and the next week we'll do that. We'll get salt out and then we'll check and see how much your mobility is increased. Just do it for a week. And so the term is, I find very helpful. And I just wanted to know if that's included in part of your studies.
It is in the context of substance use, but I'm more interested in the way you framed it, because you framed it much more broadly than that. I haven't used it in that way before, but I certainly would be interested to maybe afterwards, if you have a material on this. Harm reduction is very widely used in the substance use world. Take it in steps and look at how you can reduce harms rather than abstinence, etc. And yes, with all our work on alcohol, which is a major risk factor for chronic diseases, we do a lot of, in fact, all the motivational enhancement work is around reducing harm as a first step. Yeah, correct, exactly, absolutely. Yeah, I think it's also quite empowering because it says, you can actually do something to reduce the harm that's associated with X, Y, and Z. And I also think that a lot of these behavioral interventions are very empowering. They're very enabling. They really try and get the person to use their strengths, to use your metaphor.
Well, that was truly fabulous and really a pleasure for all of us. Thank you again. Please join me in thanking you. A couple of quick announcements before we all disperse. Of course, you all know that right afterwards we have a little coffee and snacks so we can continue this discussion and networking. I want to remind people about our letter of intents for our pilot grants, which are due January 15th. And our next session, I think, speaks a little bit about this sort of community-based collaborative model. It's a case study from Cooley Dickinson's Hospital in Western Massachusetts, and it's about the integration of naturopathic medicine and primary care medicine in a clinical setting. So it's going to be Dr. Rockwell and Dr. Rothenberg. So this will be an interesting session next month. So please, if you did not sign in on your way in, please put your signature there. It's important for us to keep these metrics. And thank you again for coming. Hope to see you next time. And thank you again to Dr. Patel.